Thank you all for coming tonight. We're really honored tonight to have Dr. Jonah Murdock, who is arguably one of the most experienced neuro-urologists in the country, and has certainly done the most work with Ehlers Danlos Syndrome and Tethered cord syndrome of any urologist probably in the United States or Europe for that matter. And I feel like this is a very complex area, and Jonah has always tackled these problems with a great deal of sophistication, and I can trust his opinion on these issues better than any other urologist I've met, and there are a lot of good names out there. Jonah graduated with honors from Carleton University, completed his PhD at Northwestern, was graduated with a medical degree from University of Illinois, and then interned at the Washington Hospital Center, did his residency in urology at Georgetown University, where he continues to teach the philosophy of medicine, and he is presently with Atlantic Urological Associates. So I'm very pleased that you can speak tonight, and Dr. Jonah Murdock.
Well, thanks a lot for having me. My experience with about 500 Ehlers Danlos patients and patients with Chiari malformation has come over the last 7 years, and a lot of that has come because of my association with Dr. Henderson, and also somewhat with Dr. Francomano in Baltimore.
Can I interrupt? My hearing's not that good.
Oh yeah, I'll raise my voice.
Speak a little louder. And the machine or the vents are running, so I can't.
You may want to move right up front then.
So,
because the microphone isn't.
Can you hear me now? So I've had experience with about 500 patients with Ehlers Danlos Syndrome, many of whom have Chiari malformation as well. And based on that experience, I've come up with a certain amount of understanding of the urologic problems that affect this population of people. Let's start with the case. This is the case, this is from a couple months ago. A 32-year-old female presented with urinary retention. And what are these squiggly lines? This is urodynamics. One of the goals of today's presentation is to understand what this is. This is one of the tools that we use to understand whether the bladder is functioning normally or not. I'm going to explain a little later on how we do the urodynamics, but let's just talk about the results on a piece of paper. This is the pressure in the detrusor in the bladder, this green line, and it's calculated pressure based on the pressure that's measured in the bladder, which is blue, subtracted from the pressure in the abdomen, which is red. So these are two measured pressures, and we subtract one from the other, and we get our calculated detrusor pressure, the pressure inside the bladder. And this is the pressure in the urethral sphincter that's obtained directly when we put a monitor next to the sphincter muscle. So here's the pressure of the urethral sphincter, and here's the pressure of the bladder. And this is the flow of urine. It's not happening over here, but it is happening over here, and this is the measurement of the flow. So in this patient, we were trying to figure out why she was in urinary retention, and what we found out was that here, when she was trying to urinate, she decided, okay, now I'm going to urinate. First her bladder filled, and the pressure remains low, because when your bladder is filling, the pressure is low at all times in the bladder. And then at a certain volume, someone feels like they have to urinate, and when she started to contract her bladder and to try to empty it, the muscle of the sphincter started to tighten, started to contract and tighten. So just at the moment that the muscle was supposed to relax to allow the urine to come out, instead it was tightening. And this is not normal. And this is the reason why her flow is so poor and the reason why she presented in urinary retention. This finding is something that we're going to get back to. So here is a problem, and here is a way of figuring out the origin of the problem that you can't get just from taking a history or examining someone. Here is this finding blown up a little bigger. You can see that the bladder is trying to contract. It's not generating huge forces, but that the sphincter is contracting even more, stopping the flow, and therefore the flow is very poor out of the bladder. So we have this increased sphincter contraction and prolonged urinary flow rated void. There we go. Normally we would have sphincter relaxation with increased bladder contraction. Let's contrast this with, say, BPH. I don't know if you know what BPH, the hypertrophy of the prostate, which afflicts a lot of men, and they have a lot of trouble urinating, and they present all the time not being able to urinate. And in their situation, when their bladder contracts, you wouldn't get this sphincter contraction, right? But you would have a poor flow. So if you didn't have this monitor in place, you wouldn't be able to distinguish someone unable to urinate because of the BPH and someone like this who's unable to urinate because their sphincter is acting incorrectly. It's dysenergic. It's contracting when it's supposed to be relaxing. But this does not happen in someone that has BPH problems. So that's how you can tell the difference. Say if this was a man who presented with urinary retention and he had Ehlers Danlos Syndrome, you would easily be able to tell the origin of the problem in this test. I hope I'm not losing you. The purpose of this is to draw you in so that you understand kind of one of the central ways that we can try to measure problems in Ehlers Danlos Syndrome that come up that are urologic. Here's a second case. This is a 40-year-old female who presented with Ehlers Danlos Syndrome and urinary frequency and hesitancy. So while her bladder is filling, okay, here's the addition of well, here you can see down here, the volume in the bladder is going up slightly. You see that? So that's us introducing fluid into the bladder until a certain period where the patient feels like their bladder is full. So this is the time that elapsed during filling, okay? And this is the full bladder at this moment in time. Well, you can see that as the patient's bladder is filling, instead of maintaining a low pressure during the entire filling phase, which goes from here in point A, to, time period A, to this time here, periodically the pressures are increasing in the bladder. And that shouldn't happen. As your bladder fills, it should always be low pressure. And so this means that this person, periodically, while the bladder is filling, she's having contractions of her bladder. And then, when she finally is full and she tries to urinate, her bladder contracts, but at the same time, her urethral sphincter contracts even more, obstructing the flow of urine, and therefore the flow is very poor. And that's why she comes with hesitancy of urination, because the urine just doesn't flow out easily because it has to overcome a contracting urethral sphincter that is working against the flow of urine during the process of micturition, which is the process of voiding. So this patient has two problems. This problem is like the first patient, and then the second problem is this problem. This problem is the same exact thing that's seen when somebody has overactive bladder. And we're going to talk about this. So if a patient shows up and they have this finding only, you think, well, maybe they have overactive bladder. This is bladder contraction during filling of the bladder that doesn't have any obvious neurologic cause. Or you can see this in a patient that has a neurologic cause, like multiple sclerosis, or problems with their spinal cord or other problems like in Chiari malformation, patients can present with this issue, and it can be caused by their neurologic issues. But the fact that this patient presents also with this issue, which is only occurs in patients who do have neurologic issues, means that this problem is also likely caused by the neurologic issues that are in the background. So we can say that this urinary frequency and the hesitancy are both caused by the central issue that's likely neurogenic, likely caused by the underlying neurologic problems. And that's the power of this kind of test, this kind of urodynamics. The goal of my talk today is to understand the relationship between Ehlers Danlos Syndrome, Tethered cord syndrome, Chiari malformation, and neurogenic bladder. And I need to define the role of urodynamics in helping to diagnose tethered cord and other problems that come up in these conditions. I've given you a little hint of that in the first two cases that I presented. I hope you're paying attention because there's going to be a review quiz at the end. You think I'm joking? Let's define our terms. Ehlers Danlos Syndrome, this is a very general slide. It's a group of genetic connective tissue disorders. There's a defect in collagen production or structure or defect in proteins that interact with collagen that results in the disorder, the syndrome. Its incidence is probably 1 in 5,000 individuals, and the most common type is the type 6 or hypermobility type. There's a myriad of symptoms of Ehlers-Danlos, and I won't review them here. What is Chiari malformation? Well, there's Chiari 1, 2, and 3. 2 and 3 are very uncommon, so let's talk about Chiari 1. It's characterized by an underdevelopment of the posterior cranial fossa and overcrowding of a normally developed hindbrain. Its symptoms are due to CSF disturbance and compression of nerve tissue. I'm not an expert in neurology. This is kind of my take from what I know, which is not a lot. About 14% of patients with Chiari type 1 have tethered cord. And the urinary symptoms of Chiari malformation are that 17% of patients with Chiari present with some type of urinary incontinence, 22% if they have syringomyelia, then 22% present with incontinence, and 10% of male patients present with impotence. What is adult tethered cord syndrome? Well, this is the sequelae of the injury to the distal spinal cord and filum terminale. The nerves serving the plexus of the pelvis, for example, the bladder, and the lower extremities don't function normally in adult tethered cord syndrome. In Ehlers-Danlos patients, we think that this is due to deformative stress from hypermobility of vertebral joints. How common is it? We don't know. It hasn't been measured, but it's fairly common in Ehlers-Danlos patients. The urologic symptoms are not specific. They're frequently not acknowledged or not understood by the patient, but some symptoms are the patient can't feel when their bladder is full, okay? And they always feel full. They might have severe straining when they void, or they might have intermittent urinary stream, or be unable to void entirely. So there's a lot of different urologic presentations, different types of urologic symptoms of tethered cord syndrome. If you look at this literature review, the average age of symptom onset for adult tethered cord is 36.5 years old, and the predominant symptom is pain and weakness of the lower extremities. Patients can also present with severe constipation and urinary symptoms and other symptoms. Usually they're precipitating incidents like trauma or excessive physical training, but that doesn't necessarily have to be present. What is a neurogenic bladder? Let's define this term. So all of our terms are defined from the outset. It is bladder dysfunction caused by neurological disease. Oppose that to bladder dysfunction not caused by neurologic disease. There's plenty of bladder dysfunction not caused by neurologic disease that would be excluded from being neurogenic. Types of The types of neurogenic bladders are characterized by the bladder symptoms. For example, hyperreflexic neurogenic bladder, also known as spastic or hypertonic bladders, are bladders which are contracting frequently and involuntarily, and this would be due to a neurologic problem. For example, another type of bladder, neurogenic bladder, defined by the bladder symptom that results from it, it would be a hypotonic, or some people say an acontractile neurogenic bladder. This is where the bladder doesn't contract well due to a neurologic disease. Also, you can have a sensory problem where the bladder could contract well, but the patient doesn't feel the need to contract their bladder, to empty their bladder. They don't feel full. And that could also be due to a neurologic disease. Now my talk gets slightly more technical, and maybe too technical. But suffice to say that the symptoms of the neurologic symptoms are determined by the level of the neurologic disease. For example, if the problem is above the level of the pons, then usually patients present with hyperreflexia, and they present with synergy between the bladder and the sphincter, meaning when the patient voids, the bladder contracts just after the sphincter relaxes, and these things are done in the proper synergy with one another. Dyssynergia would be the patient is getting ready to void, and the sphincter would contract at the moment that, or just before or during the contraction of the bladder, and then the bladder contraction would be working against the sphincter contraction, and that would represent a dyssynergy between the detrusor or bladder muscle and the urethral sphincter. So if the level of neurologic disease is above the pons, then usually there is synergy between bladder and sphincter, and usually the neurogenic bladder is hyperreflexic. If the patient presents with a sacral problem, very low problem, then classically the neurologic problem is bladder hypotonia, or a hypotonic neurogenic bladder. And if the patient presents with suprasacral problems between the pons and S2, then generally speaking, although not always, because it depends on the extent of the problem, the book would tell you that the patient should present with a hyperreflexic neurogenic bladder that may or may not have dyssynergia or synergy between bladder and sphincter. These are just general rules of thumb. They don't work for every patient. Detrusor sphincter dyssynergia, let's review the definition that I've already kind of alluded to. This normally during, there is contraction of the, let's start again there. Detrusor sphincter dyssynergia consists of contraction of the urethral sphincter during micturition due to neurologic disease at the time of bladder contraction. This term is reserved for there being a neurologic cause. If there's not a neurologic cause, then we call this pseudodyssynergia. For example, classically in the urologic literature, this would be a teenage patient who has learned how to void dysfunctionally. They, for some reason, taught themselves that when they need to void, they feel like they need to void. They've taught themselves to contract their urethral sphincter at the time that their bladder is contracting, and that it's not due to a neurologic problem, but rather a behavioral issue. People maybe they are having some type of emotional problems. Classically in the literature, that's the way that's been described. It's not very common. Pseudodyssynergia is not common in my view. Most dyssynergia is true detrusor sphincter dyssynergia. So, reviewing what I've already discussed, The bladder fills. During bladder filling, the pressure remains low, even though the volumes are getting higher and higher. At some point, the bladder senses that there should be that the bladder is full and that there should be emptying of the bladder. Then the bladder volitionally contracts, but just prior to that, the sphincter relaxes, allowing the urine to flow, and that's the process of micturition. It's a low pressure. Voiding is normally low pressure because the sphincter is relaxing during voiding. Therefore, there's very little resistance to urine exiting the body. If the patient this patient does not have a prostate, this is a female, if the patient has a prostate which surrounds this urethra, then the resistance to the urine exiting the body is slightly higher. Micturition is a slightly higher pressure event, but it should remain a relatively low pressure event in normal voiding. To review again, in a neurogenic bladder, if there were detrusor sphincter dyssynergia, for example, the sphincter would contract during voiding, and then patients would present with hesitancy and straining at void, which makes sense. And in the event of a hypercontractile neurogenic bladder, the bladder is contracting during the filling of the bladder. Instead of it being a low pressure event, all of a sudden filling becomes a high pressure event, and then micturition occurs involuntarily, and incontinence occurs. Does this make sense to everyone? I don't know if we need to talk about this slide. The conventional view of Ehlers Danlos Syndrome is that, in the urologic literature, is that the urologic symptoms are due to the abnormal connective tissue of the bladder. And so, because in many patients, let's simplify Ehlers Danlos Syndrome to patients who have stretchy connective tissue, okay? And the bladder, in some patients who have Ehlers Danlos Syndrome, it gets larger and larger and larger over time, becomes a giant kind of sac that holds many, many times the normal amount of urine that a bladder should hold. A normal bladder should hold, in a woman, about 300 cc's when the woman feels full. In a man, maybe 400, but not more. I have patients with Ehlers Danlos Syndrome, they present with bladders that hold 4 times that amount, like maybe 1.2 liters, and they don't even feel full. And for some patients that have Ehlers Danlos Syndrome, that's due to a stretching out of the bladder over time. And they can develop what's called diverticuli, which are sacs that are protruding from the bladder. So you'd have the main bladder, and then you'd have extra diverticuli or sacules of bladder holding urine in them also. And these types of patients have been known classically in the urologic literature for a great while, and when urologic textbooks deal with Ehlers Danlos Syndrome, which is rarely, they refer to this problem. And then their answer is that we should do surgery to take the diverticuli away, to remove the diverticuli, to make the bladder a single entity. And other issues that occur in patients that have Ehlers Danlos Syndrome due to their connective tissue, other issues that are urologic are they can have prolapse and incontinence. And so many women, for example, with Ehlers Danlos who deliver children, afterwards they have a much higher risk of prolapse of their vagina and their bladder than the general population. How much of a risk? No one really knows. There aren't studies on this. But I can tell you from seeing all these Ehlers Danlos patients that a lot of these women that I've seen have had prolapse issues. The Ehlers Danlos can result in the bladder laxity, and the large saculated bladder that can result in poor bladder emptying and a bladder that's prone to urinary tract infections. If the patient presents with urinary tract infections, the purpose for treatment, the goal of treatment would be to empty the bladder more completely each time. And the way we do that is timed voiding. So let's say a patient wouldn't feel full. I've seen a patient like this. They come in, they say, I void once every 15 hours. I don't feel full for 15 hours. And then when they do void, they void a substantial amount of urine. So their bladder is very high in volume. You would tell them, you need to void every 3 hours. And if you do that, over time, the bladder should get smaller, or at least not larger, and they would avoid urine stasis in the bladder for those 15 hours, and it would make them less prone to urinary tract infections. That's a simple way to help Ehlers Danlos patients with this problem avoid UTIs. Also, patients can double void, try to urinate, and then wait a minute, and then try again to better empty. That can also frequently help. A bladder diverticulectomy or surgery is very rarely needed. Patients who have prolapse can have that fixed surgically or not, and I should say that Ehlers Danlos patients, I think, should use caution due to poor wound healing generally, and poor outcomes from repair of prolapse have been reported. Okay. What's the relationship? Let's get back to the main topic of today's lecture, which is Ehlers Danlos Syndrome and neurogenic bladder and tethered cord issues. So here's one of the patterns that I've seen over the last 7 years. Patients present with hyperextensibility of the spine from Ehlers Danlos. They have deformative stress injury, and they end up with tethered cord syndrome. We don't know how many of these patients there are exactly, but there are many. And then they present with, and this is where I kind of started off not knowing 7 years ago. I didn't know many patients, or any patients 7 years ago with Ehlers Danlos syndrome, and we didn't know how many of them had bladder hypotonia, how many of them had hypertonic bladders, and how many of them had detrusor sphincter dyssynergia when they presented with tethered cord syndrome. But we now know, at least I know, that they present with all three types of neurogenic bladder and with about equal frequency. When patients present with tethered cord syndrome, their pelvic and sacral nerves are not functioning well, and they're unable to, their bladder's either unable to store urine properly, or they're unable to empty, and so they present with they don't feel when their bladder's full, they always feel full, or they have severe straining and intermittent stream when voiding. Urodynamics is useful to help diagnose the neurogenic bladder. What is urodynamics? So I started off with 2 cases of urodynamic tracings, okay? But the way you think about urodynamics is that it's 3 tests stuck into one kind of group of tests. First, you measure the bladder storage. That's called the cystometrogram. You're filling the bladder, and you're measuring the pressures in the bladder and the volumes that are stored in the bladder as it's filling. Then you measure voiding, where you measure the pressure and the flow of the urine at the same time during voiding, and you measure the contraction pressures of the sphincter during voiding. That's called the EMG, electromyogram. And those two together are going to be used. The electromyogram and the pressure flow study is going to tell you the full picture of the relationship between the sphincter and the bladder. Urodynamics can be used to uncover occult bladder dysfunction. It can confirm a clinical and radiologic diagnosis of tethered cord or neurogenic bladder or other problems, and it can identify response to treatments to these problems. What is the technique of doing urodynamics? We place pressure sensing catheters in the bladder, and we do that by putting very tiny catheters into the bladder, one very tiny catheter into the bladder, and inside the bladder it's measuring the pressure, okay? Then we put pressure measuring sensors near the urethral sphincter, right down here, to measure, that will measure the sphincter. And therefore, we'll be able to measure the pressure in the bladder when it's filling, during voiding, measure the sphincter, and make a urodynamics picture that could look like this. So here we are. This is maybe a 5-year-old urodynamics tracing, maybe more. Here is the bladder filling with urine, with fluid. We'll fill the bladder slowly with fluid, and we're supposed to fill it slowly because it's supposed to mimic physiologic filling of the bladder. So the bladder usually fills at 30 to 40 cc's an hour. Okay, that's about how much urine you're making, unless you're really dehydrated or overhydrating. And so it's been decided that if you fill, let's say you took hundreds and hundreds of liters per minute and poured and filled up the bladder that way, the bladder might not act normally, right? So we slowly fill the bladder at 50 cc's per minute. Some people as slow as 10 cc's per minute. We usually fill at somewhere between 30 and 50 cc's per minute. So we're filling the bladder and filling the bladder, and as we're filling this patient's bladder, you're noticing that the bladder pressures are increasing in this kind of episodic way. This is an involuntary contraction of the detrusor muscle, which might reflect a hyperreflexive neurogenic bladder, or if the patient doesn't have a neurologic cause, this would be classic for overactive bladder. Okay? And here you see that the patient's bladder, the patient feels full, they attempt to micturate. During voiding, this is the pressure in their bladder, and notice how the pressure in their sphincter is low. It's not high. So this patient does not have detrusor sphincter dyssynergia. There's a synergy, a relaxation of the bladder at the time of the contraction, the relaxation of the sphincter at the time of the bladder contraction. And this flow rate is good. You'd have to look at the numbers to confirm that the flow is good, but I can just tell you that it is. And then this is the urine amounts coming out. Here is detrusor sphincter dyssynergia. Here's bladder filling. You could say, oh, what is this? Well, this might be involuntary contraction suggestive of hyperreflexia, but sometimes when contractions occur near when the bladder is totally full, this might just be a artifact of the test. Okay, so we don't really know. And then the patient's saying, oh, I'm full, I need to void, and right before they start to void, look what happens. The sphincter contracts, right? So you're having massive sphincter contraction and then contraction of the bladder. So what's supposed to be happening is relaxation of the sphincter followed by contraction of the detrusor. We have the opposite. This is detrusor sphincter dyssynergia, and if it's in the context of neurologic disease. Very helpful. And here's a bladder. Can't see this. Basically, when we do urodynamics, usually we put in 1 liter, sometimes 1.25 liters in the bladder, and that's how much saline is in the bag. Here we've put in 1 liter into this patient's bladder, and the patient doesn't feel full. They don't even feel like they need to void, and my technician would be marking, patient feels full, patient feels like they need to void. There's no mark of any kind. The bladder pressures remain the same, and the patient never feels like they have to go. So here's a patient who basically has lost the sensation of having a full bladder, and the bladder just fills and fills and fills, and has an enormous capacity. This could be for many causes. Here's a patient who I think that's 600 cc bladder capacity, so the bladder is filled to 600 cc's, and then there's contraction of the bladder when the bladder feels full, and relaxation of the sphincter, so there's no dysynergia, and yet, look, the urine is dribbling out, right? It's coming out in dribs and drabs over an extended period, right? So contraction of the bladder, but poor flow of urine. What could that be? And the sphincter is relaxing. What could that be due to? Either the contraction of the bladder is inadequate to empty the bladder, or there's another level of obstruction. For example, there might be a urethral stricture, or there could be BPH, right? So if the contraction pressures are high, then and the flow rate is low and intermittent, then that could be due to stricture or BPH, some other bladder outlet obstruction, an obstructed urethra. However, in this case, if you measure these contraction pressures, they're very low. So this patient's bladder is actually not contracting, and that's why they're not generating any flow. And so this patient has bladder hypotonia. Any questions so far? I'm hoping this isn't too technical, but this is really what we're trying to.
I've got a question.
Yeah, sure.
If you had a diabetic bladder,
Yeah,
that would cause the same condition of a.
that would look like that. Yeah, the patients with diabetic bladders frequently, so there's different types of diabetic bladders. Some patients present like this, where they can't generate any contraction. But a lot of diabetics present actually initially like this. They've lost the sensation, and their bladders come in with 800-900 cc capacities, and they don't feel full. And so if you catch someone early enough in the diabetic disease process, then you can say to them, well, you can still contract your bladder even though you can't feel it. So you just need to do timed voiding. So every 3 hours they empty their bladder, and then they're fine. But then over time, frequently those patients progress as the diabetes progresses, and then they can't contract their bladders, and then we have a bigger problem.
So it's both a problem of loss of ability to contract, or a hypotonic bladder, as well as loss of the sensation.
Mm-hmm. And frequently the loss of the sensation occurs first. Yeah, that's a very difficult problem to treat. Where were we? Okay, so when you have a patient with Ehlers Danlos Syndrome, it's a difficult clinical puzzle to identify whether the cause of the bladder hypotonia, for example, is due to bladder muscle laxity from the connective tissue disorder or from a neurogenic bladder. And this is one of the main problems dealing with patients who present in this fashion. Is it the connective tissue disorder itself that's causing the bladder dysfunction, or is it a neurologic problem in addition that's causing the problem with the bladder emptying? Most urologic texts focus on the bladder muscle laxity problem, and they haven't, because it's not well published, they're less focused on and less willing to acknowledge, thus far, urologists have less acknowledged the role that neurogenic bladder plays in patients with Ehlers Danlos Syndrome. I think that's because it's just not well published. Let's look at another scenario. An Ehlers Danlos patient presents with atlantoaxial instability, Chiari malformation, and a tethered cord. All these problems could result in neurogenic bladder dysfunction. So we would recommend imaging to try to figure out which one might be present. And it's a difficult clinical puzzle. Is it Chiari that the patient is presenting with that's resulting in their urologic symptoms? Is it tethered cord? Is it another cause? Is it just overactive bladder and unrelated? Right? So that can be a really difficult clinical puzzle, and I don't want to get into that too much today, but basically you can try to figure out from the type of urodynamic problem that they have where in the neurologic system the problem might be coming from. For example, if the problem is hyperreflexia, it may be that it comes from the pons or above. But that's just a general rule, though. What does the urologic literature have to say about urodynamic findings in tethered cord? Well, there's not a lot of consensus. I don't want to belabor this too much, but I have about 5 or 6 slides on what's in the literature. Here's a study done 17 years ago that said that patients present with urgency and urgent continence half the time, and patients frequently have detrusor hyperreflexia, and some have sphincter dysynergia when they present with tethered cord syndrome. Here's a study from 30 years ago that says that patients who present with tethered cord syndrome half the time have a so-called flaccid bladder or hypotonia, and a quarter of the time have hyperreflexia, and sometimes have normal urodynamics, but not commonly. Also, by the way, interventions to treat the tethered cord resulted in resolution of bladder symptoms about half the time in this study. Here's another study from 30 years ago that said that about 2/3 of patients restored bladder function after surgical interventions for tethered cord syndrome. Here's a study from 7 years ago. Patients who presented with adult tethered cord syndrome, 48% had urinary symptoms, and 47% had post-surgical improvement of their urinary symptoms. So the next one. Here's a study from 25 years ago. 31 patients who had spina bifida occulta, and after tethered cord surgery, 72% had their incontinence resolved, and 59% had their detrusor hyperreflexia resolved, and 2/3 had bladder compliance issues resolved. So some of these studies, here's a study that says that tethered cord, a study of tethered cord in the absence of imaging abnormality. There's 32 patients who presented with urinary dysfunction, stool incontinence, or severe leg or back pain and had normal imaging. And after surgical sectioning or detethering, after detethering, 97% experienced significant relief in symptoms. So this points to the fact that urodynamics and urinary and evaluation of urinary issues generally can be very helpful in determining who might respond to detethering. Here's a series of Dr. Henderson's patients that I reviewed 5 to 6 years ago. It was 43 patients that we shared. Since then, we've probably, I could look back at probably about 400 patients, but here are 43 of them. All of them had symptoms of tethered cord. 85% had radiologic evidence of tethered cord. 60% had urologic symptoms, and 50% of those patients had Chiari malformation. So many of the patients with Ehlers Danlos had Chiari malformation also. This was the symptom questionnaire that they were asked to answer. Okay. Focuses on urologic issues, lower extremity issues, and bowel issues. 75% of those patients had abnormal urodynamics, And like I said at the beginning of this talk, like I alluded to, 37% of them had hyposensory bladders, 34% had bladder hypertonia, and 28% had detrusor sphincter dyssynergia. 25% of the 43 patients had normal urodynamics. We looked at 20 of those patients after they had detethering, okay? So we took a subset of the 43, so this is about half of those patients who actually elected for surgical management, and those patients, 50% of the 20, so 10 of them had Chiari, 80% of those people of those who underwent detethering had abnormal urodynamics, and 84% of them had improvement in their symptoms. So this is pretty consistent with those papers that I reviewed just 5 minutes ago, but this is specific data on Ehlers Danlos patients that come out of Dr. Henderson's patient group. So what are my conclusions? Assuming a patient has tethered cord, and that's determined by the neurosurgeon, they could have detethering. If they have residual symptoms after their cord is untethered, what can we do? Well, for detrusor sphincter dyssynergia, we can use alpha blockers. These alpha blockers are medical agents that relax smooth muscle, and so that can result in some amelioration of symptoms from contraction of the sphincter at voiding. It's not that successful, but it can be helpful. Patients who still have large capacity bladders can perform timed voiding frequently, and patients who have hypercontractile bladders can use antimuscarinics. These are agents that are commonly advertised on television, like Vesicare. They're given to overactive bladder patients, frequently marketed to middle-aged women, but applicable to a much wider population of people. They have mixed success in this population of patients, very, very mixed success. So what can we say from my experience with these issues? Almost all patients with tethered cord syndrome have abnormal urodynamics, but not all. There's a pretty equal incidence of bladder hypotonia, hyperreflexia, and detrusor sphincter dyssynergia among those patients. Some of the Ehlers Danlos patients have a neurogenic bladder even in the absence of urologic symptoms. I've met some patients like that. And this can be identified on imaging or at urodynamics. Patients don't realize that they're having urologic problems, but you can see it when they do a urodynamic test. And not all patients with tethered cord have abnormal imaging or abnormal urodynamics. Urodynamics can be a good test, good diagnostic test alongside clinical symptoms and radiography in helping to diagnose tethered cord and predicting good response to surgery. Ehlers Danlos patients with Chiari malformation have almost as good a response to tethered cord surgery as those without Chiari malformation, but my experience with that is small. Larger series are needed to be published. Frequently, urodynamics post-intervention can be helpful, but not necessary if patients experience amelioration of all symptoms, of course. Let's come back to this, let me see here. Yeah, this case. This is the final examination. This is my last slide. Does anyone know what's happening here?
You have a sphincter dyssynergia, detrusor sphincter dyssynergia.
So during contraction of the bladder, there's contraction of the sphincter, so this is dyssynergia of the sphincter, and that explains the patient's hesitancy. Anything else?
Yeah, the pressure.
Right. So we're having cyclical contractions of the bladder, increasing pressure in the bladder as the bladder is being filled. This might be indicative of overactive bladder, which should have a non-neurologic cause, or in the case of this patient who has Ehlers Danlos Syndrome and detrusor sphincter dyssynergia, this is likely has a neurologic cause. If you show this urodynamics evaluation to like a world's expert on urodynamics, they frequently think that this is actually made up. Like I've shown this to, I took a course in urodynamics from fancy urologist in New York City, and I told him about some of my experiences, and I showed him this, and he said that's not real. But I see this all the time.
Yeah.
Well, any questions?
I think I saw that, I guess, post-surgery data is lacking. I guess, was that meant for the urodynamics? Or have you had the opportunity to perform urodynamics after
Sure.
detethering? Or
Sure, but usually we don't. And so what happens is patients, and I have a dozen or more patients who I've seen years after detethering who think that they presented with retethering.
Mm-hmm.
And so then we redo the urodynamics, and then I get to talk to them about what happened after their tethering. But I'm not an expert, I'm not a neurosurgeon, so I'm not an expert in that. If we were doing expensive tests on patients who didn't need to have the test done because they had already responded to treatment well, then I think we would find that their urodynamics was normal.
I mean, I can definitely say I had tethered cord surgery 6 years ago, but prior to that, for as long as I can remember, enormous bladder. I mean, maybe would only go to the bathroom twice a day.
Right.
Didn't have the urge to go. When I had the urodynamics, they actually went into the second bag of fluids.
Right.
Because I still didn't even have the smallest urge.
Right.
After my phylum was released, from that day on, even presently, if I have like a cup of coffee and a water right after it, I have an urge. But I don't know how many years I lived with rarely getting an urge. And then at the end of my test, the woman said to me, okay, now I want you to void, but don't push. And I went, what do you mean don't push? I never knew my whole life that it was not normal to push when urinating.
Right. So you may have had detrusor sphincter
I
dyssynergia
did,
also.
yeah.
So the thing is that most urologists, they don't know about Ehlers Danlos Syndrome at all.
Mm-hmm.
So if you went to them and ended up with a urodynamics test, or you just went for a consultation about your urologic issues, they probably wouldn't put together the problem of Ehlers Danlos and with your problem. But let's say they did, they would probably have said, well, you have a connective tissue disorder in your bladder that's resulting in massive bladder enlargement. Your bladder is stretched out over time. And so they might have left it at that.
Right.
But the real thing to do is to also go the route of, well, is there tethered cord occurring here? And to try to make sure that tethered cord isn't also present.
Right.
And that's how that goes. And the problem is that a lot of urologists don't understand those couple of moves.
I know with my kids, the pediatric urologist they have seen has said, oh no, you have EDS, you have big bladders, they're stretchy, time voiding is the answer, but really it was tethered cord.
Right. Those are urologists who have made one that they have some understanding, but they're not. They don't understand Ehlers Danlos Syndrome enough to understand that the tethered cord is a substantial issue for a large number of people.
Exactly.
That's common.
Mm-hmm.
I don't know if you would be the one to answer, Dr. Henderson, but for our patients that are still having urologic symptoms after surgery, how long should we let everything settle, like heal and everything, before we send them back to get more, like back to you?
It's a good question. What do you think? I think patients should see within 1 month, they should see a big change. If you're not seeing a change, it may be because your symptoms were not due to the tethered cord, and when you're when you have detethering, you may have improvement in other symptoms that might have been caused by the tethered cord. The urologic problems may not be caused by the cord tethering, and it may not respond to cord detethering. Usually within a month.
In the neurosurgical literature, and maybe this is because neurosurgeons, want to, deflect any criticism about the surgery, but typically you hear 6 to 12 months time should be allotted for urological.
Do you think that's accurate?
What? I see the full gamut. Some people see improvement within a few weeks, and some people take longer. So I really don't know.
It has a lot to do with how long you've been tethered, right? Or it can have to do with that.
Yeah, good.
I'm not a neurosurgeon.
There's I think there's a lot we need to learn about tethered cord, and there are a lot of very good studies that show that occult tethered cord syndrome is, or the treatment of occult tethered cord syndrome is very effective. But none of the studies have really been set up terribly well. They don't have good, reliable exclusion criteria and inclusion criteria. We don't have standardized metrics with which to compare patient populations. You are careful to define your terms tonight, but most studies, look at the different terms, and there's a muddling of precisely what constitutes a neurogenic bladder versus a spastic bladder. I think that there's a great deal of work that needs to be done in this area to make the diagnosis more precise. And you're one of the few urologists that actually goes through this algorithm. And most urologists just seem to look at the big picture and then make a rather arbitrary assessment. What
happened was, when I started seeing some of your patients 7 years ago, I didn't know what to do. And I had to come up with an algorithm that would fit with what a neurourologist would think without really having learned in the books about this particular presentation. So I'm always trying to refine it to make it better, I think that we don't know a lot more than we know. I mean, I certainly don't know a lot more than I know on this issue. Yeah. But this is about as far as I've gotten with it. There's a lot more to go with it.
Right. I was going to ask you about pudendal nerve latencies.
Okay.
Do you think that may be an accurate assessment of neurogenic bladder?
You mean measuring a pudendal nerve latency?
Yeah, like doing might explain what that is, too.
Right, so the pudendal nerve is controlling the sphincter, basically. So you can measure any nerve, the conduction through the nerve over time, and so how slow is the nerve working, let's just say, okay? So I take it that's what you're asking. You're saying if I'm measuring how slow this pudendal nerve is working, could that be a surrogate for neurogenic bladder instead of this funky testing, or maybe as an adjunct, right? I think that's a good idea. I've never seen anything that does that. I've never seen a study of that or anybody who said that, but that could be very useful.
Yeah, well, that was a discussion with a urologist in Baltimore who's very good, and we sort of came up with that. Is that a difficult test to do, a pudendal nerve latency?
Shouldn't be that difficult.
You could start adding that on.
It's something to think about.
Right.
Certainly something to think about.
Also, we use drugs like Bethanechol.
Right. I didn't talk about Bethanechol. I could have talked about that. You want me to mention it? So Bethanechol, it improves bladder contractile pressures, but it also, in the process, increases sphincter contraction. So frequently, even in patients who have hyporeflexic neurogenic bladders or acontractile bladders, it could jumpstart them, and that's the way it's typically been used in the past and by neurosurgeons and by some urologists. Patient comes, they have some type of neurologic injury and maybe acute, and they're trying, and you give them Bethanechol, hoping that their bladder can contract enough to generate enough force to empty their bladder. Urine. The problem is that frequently you have contraction of the sphincter at the same time, which is kind of negating that effect. But sometimes it works. It's variable.
But if you give Flomax at the same time.
Right. You could give Flomax at the same time, and yes,
Right.
they're right.
Right.
Yeah, for sure. I mean, it doesn't work in everyone. I wouldn't even say it worked in some. It works in some. Yeah.
Right.
Yeah.
And we also give pyridostigmine.
Right.
Can you talk about that, Mestinon? Yeah.
I mean, I don't do that. This can be a bladder contracting. It could be a stimulant for bladder contraction. Do you use that?
Sometimes. If
Sometimes?
we need to augment the.
Do you think it works?
I'm not sure, but we do use Mestinon to increase bowel contractility
Right.
for gastroparesis.
Right.
And I think it does work for that. And it's also thought to help stabilize the sympathetic hormones.
Mm-hmm.
And it may, if in some patients, it may sort of stabilize the neurohormonal output in the body and bring it closer to normal. But again,
Right. Well, yeah, and I didn't talk about POTS syndrome and Ehlers Danlos syndrome and patients with POTS and how they are presenting with neurogenic bladder and whether they are having worse symptoms. I find that their symptoms are more difficult to control with the standard algorithm, so something else must be going on. But I don't have a lot to say on that. I just know that it's probably something else is going on, right?
right.
That's the problem.
Yeah.
Do you know what's going on?
Yeah. Well, there are always a lot of things going on with
it's tough.
Ehlers Danlos.
That's very tough.
Well, one thing you mentioned in the textbooks, they talk about muscle weakness.
Yeah.
I don't think that's really panned out in the neurological literature, because most EDS patients are actually quite strong.
Right.
In fact, a lot of them are great athletes.
And that's why they can still empty their bladders even though the bladders become huge and sacculated. So most of the time they come in, their post-void residuals are 10 or 20 or 30, even though their bladders were massively sacculated. And most patients who come in like that in a urologist's office are 90-year-old men whose bladders will never work. And so we're typically dealing with that kind of patient with a massive sacculated bladder. When a 35-year-old woman shows up with a massive sacculated bladder and it works, it's kind of an interesting phenomenon. That's what you're talking about. The muscle contracts, but somehow there's something going on in the wall of the bladder that has resulted in it getting stretched out over time. That's a colloquialism, but right, so it functions. And that's a great thing for Ehlers Danlos patients, because with timed voiding, most can avoid issues. Because they can, most of them can empty.
One of the problems you mentioned, sacculated bladders. One of the problems with EDS patients in the hospital is that they can have a Foley catheter which doesn't empty the bladder because there's a sacculation that's still
Right.
enlarging.
Absolutely.
And this is not commonly understood. In fact, I only learned about this about 6 months ago. And nurses become very irritated by the patient who says, well, my bladder's full, and the nurse will say, well, it can't be, you have a Foley catheter in.
Right. So what
And
you do is you would get an ultrasound, you would put it in the suprapubic region, you would see the Foley balloon, you would see some portion of the bladder deflated around the Foley balloon, meaning emptied, so the bladder's emptied, but then you would see a fluid-filled pocket next to that. So you'd see the Foley, and you would irrigate the Foley, you would see the Foley functions, but you would see a big fluid collection where the bladder is supposed to be also. And then you would hypothesize that the patient has a sacculated large bladder. That's a classic Ehlers Danlos Syndrome bladder, which is what I started with at the beginning of the talk. And that's how you figure that out. Okay. Or you can do a cystoscopy. But, I mean, most people aren't getting cystoscopies while they're in the hospital.
Right.
For other reasons. Sorry,
No, that's good, yes.
Okay.
And would you recommend some low-level antimicrobial like microdentin?
Right, so what you do is you get a post-void residual on a patient to see how much is left over in their bladder after they void. If they're having urinary tract infections and their post-void residuals are high, then you give imacrodentin. If the patient's having high post-void residuals but no urinary tract infections, then you leave them alone. But if they're having this urinary tract infection problem that's resulting from a poorly emptying bladder, either because the saccule is not emptying, which those patients should probably have surgery to remove that. But that's very uncommon. I don't see a lot of those patients. But those patients should probably have surgery to remove that saccule if they're having urinary tract infections repeatedly. But if they're not having urinary tract infections, then do nothing. Time voiding.
Could you speak briefly about sacral nerve stimulation for these patients? Is there a role?
That's pretty good. That's a pretty good question. So sacral nerve stimulation is the stimulation of the S3 nerve root, and no one really knows how it works, but it's classically used to treat patients who have bladder hyperreflexia. They either have overactive bladder or they have a hyperreflexic neurogenic bladder, which is basically the same thing in practice, which is they feel the urge to void very frequently, and they may or may not leak urine on themselves. Okay, so that's the reason why most people use sacral nerve stimulation is the generic term for the interstim device that performs the sacral neuromodulation of the S3 nerve root. And the device is produced by Medtronic, which is a giant company. So patients come, they have frequent bladder contractions, and it's not ameliorated by any medications. You insert this electrode in the S3 foramen, and then they wear a generator that's under the skin that usually lasts like 7 to 9 years before you have to replace the battery, and then they carry a device with them where they can change the stimulation amounts, higher or lower, and kind of modulate the level of white noise that the sacral neuromodulation generator exerts on their S3 nerve root. Okay, so that's what sacral neuromodulation is. So you can use that with anybody that has hyperreflexic neurogenic bladder or overactive bladder. I don't have a lot of experience with the Ehlers Danlos patients because we have to assume that a lot of these Ehlers Danlos patients have their symptoms due to tethered cord. So why would we put a Band-Aid on those patients instead of actually treating the cause? But if patients want to try sacral neuromodulation, there's an easy way to do it. About 5 or 7 years ago, Medtronic came out with this kind of easy way of testing to see if people will respond to it. So you put a nerve in with the patient awake, you put a wire in with the person awake into the S3 foramen, and put this tiny little electrode in, and you just tape to the skin, and you do a 1-week test to see if it works before you implant the device. And the follow-up to you is that the other thing that's come into vogue for treatment of hyperreflexic neurogenic bladder is Botox. Mm-hmm. So we can inject botulinum toxin into the bladder, like if this is the bladder, in little small wheels of it, about either 100 or 200 international units of it at a time, and for 6 to 9 months, it can deaden the contraction of the bladder by paralyzing most of the bladder muscle. The problem is that about 5 to 10% of patients that have the Botox injected into their bladders, they have retention for that period until it wears off. But these are problems that are they're Band-Aids. They're not treating the cause. Yeah.
In terms of post-void residual, what is your cutoff for neurogenic bladder? How many milliliters?
There's no cutoff.
What would be very suspicious for?
Very suspicious
for
in a
neurogenic
woman.
bladder? Yeah.
Suspicious is more than 100.
Okay. And what about bladder volume?
When bladder volume, when an awake, non-anesthetized woman's bladder holds more than 600 or 700 cc's without extreme discomfort, it starts to get suspicious. And above 800 or 900 cc's, it's pretty clear.
Right.
How many cc's are in that bag of saline that they
1 liter, 1,000. So if you get that bag in there and you don't feel full, to me, that's all you need. That's why you don't have to go to the second bag.
Yeah, but they said, well, you failed the test or whatever, but out of curiosity,
Right.
can we do the second bag to see how much you can safely hold? And I probably could have held the whole second bag.
Right. But over time, I found, and I've actually followed some of these Ehlers Danlos patients over the years. The Ehlers Danlos patients, some of them that are local, who have trouble with large saculated bladders that I follow. Sometimes I'll see them once a year if they want to be seen, and I check their maybe they don't empty fully, like maybe they have 100 cc post-void residual and I'm concerned about them, or they've had UTIs in the past. I'll see them back here and there, and I'll measure their post-void residual, and I'll have them do a voiding diary, some of them. I didn't talk about voiding diaries. Basically, you could take for 24 hours, you measure how much you drink and how much comes out. Get a urinal, fill it up, and you can measure how much you're voiding. And what I found is that the patients that are pretty religious or disciplined in doing the time voiding every 3 hours, their volumes of void gets lower over time, which is good. Because what's happening is, but when I see them, it's a process that's been going on for 20, 30 years, and their bladders are quite big, and then slowly the bladder, they either stabilize or they get smaller. Not normal, but smaller. That's what I found.
So, did you discuss the difference between a bladder from say, the diabetic bladder versus the tethered cord bladder?
The diabetic bladder never has detrusor sphincter dyssynergia.
Ah.
So if you have detrusor sphincter dyssynergia, it's not diabetic bladder.
Great.
And the diabetic bladder doesn't have hyperreflexia, ever.
Excellent. Okay. And what about
And the diabetic bladders tend to have poor sensation.
yeah.
But so do some of the tethered cord.
And if you have a spinal cord injury in your cervical spine,
Okay.
isn't that likely to cause a bladder urgency, frequency,
Yeah.
spastic bladder?
Yeah.
Right.
Yeah. Yeah. It's basically anything above the sacral region is going to likely have hyperreflexia.
Right.
But then the classic teaching is that above the pons, there's synergy of the bladder and the sphincter, and below can be either way. I found that some of these rules of thumb aren't that useful it's not like a hard and fast. Maybe, you probably know better than me.
Well,
Still learning.
especially when there's so many things going on.
I'm happy to answer as many questions as people want, but I bet that some of you
I have
are,
a question.
yeah.
On the screen, you said something about symptoms about walking upstairs. I didn't catch that. What symptoms was walking upstairs?
remember.
To tethered
It was
cord.
tethered cord and they evaluate you.
Yeah, oh yeah, yeah. If you're having trouble, and that was basically to measure weakness. Tethered cord can present, classically tethered cord presents with, look, I'm not a neurologist,
Yeah.
but classically it presents with a urinary symptom, which could be retention of urine, could be hyperreflexia, urgency and frequency, it could be weak stream and hesitancy from dyssynergia, for example, so you understand that now.
Yeah.
And then the other symptoms are lower extremity weakness or numbness, and classically patients can have vaginal numbness, perineal numbness, right? And then they can have constipation issues and other bowel issues.
So the walking
So,
upstairs
It would
is-
show that you'd have lower extremity weakness.
I think I have it.
Also, walking upstairs increases low back pain
That's what I was,
Mhm.
yeah.
Okay, good.
with tethered cord syndrome.
Oh, pain in the lower extremity, excuse me, I forgot that.
Low back,
Pain. Then a lot of patients present with pain in tethered cord. They'll have pain of one leg or both legs or in other distributions of pain.
Coccyx pain when you're sitting
Right.
in a chair.
Right.
Okay. Well,
Well, I'm
That's
not
right.
sure how much more I can tell you.
I think you've covered the main points, and clearly you have more experience than anyone else in the world on Ehlers Danlos Syndrome. So thanks for coming here and
Thanks for having me.
clarifying what we do know and what we don't know.
Yeah.
And we need to do some studies on that.
Yeah, definitely.
Great. Thank you.